Good afternoon and welcome. My name is Dr. Cheryl Healton, and I am Dean at the School of Global Public Health here at New York University. It has been nearly 1 month since the World Health Organization declared the coronavirus an international public health emergency. Just this week, the U.S. Center for Disease Control and Prevention has warned the United States to be prepared for the epidemic to spread here. On Wednesday, San Francisco and Orange County declared local states of emergency, and people are stockpiling masks. It could not be more timely, then, to have an opportunity to hear from New York State's Commissioner of Health, Dr. Howard Zucker. He serves on the NYU GPH Advisory Board as well, which is really very kind of him, and he was invited weeks ago to come to NYU to speak on this topic. This talk was scheduled for today when we received news that the commissioner was needed in Albany to attend a mandatory meeting on coronavirus. So Dr. Zucker is appearing live from Albany instead, and we are indebted to him for taking time from his very busy schedule to join us. So without further ado, let's move quickly to introduce Dr. Zucker and make the most of every minute we have with him. Following his talk, he will answer several questions from our faculty panelists, and then we will open up the floor to news media and audience members. Howard Zucker is New York State's chief physician, leading initiatives to plan for and prevent the spread of infectious diseases, combat the opioid epidemic, and work to achieve the end of AIDS. Since his arrival at the helm of New York State Department of Health, he has also established a network of hospitals equipped to treat Ebola, implemented programs to address the threat of Zika, spearheaded efforts to combat antimicrobial resistance and the recent measles outbreak. It is a privilege to welcome Commissioner Howard Zucker.
Thank you, Dean Healton, and thank you. I wish I could be there in person. I really had anticipated that, but I've been traveling as a result of this infection, but I did not want to miss this. So I am grateful to the NYU School of Global Public Health for organizing this panel on this issue of the novel coronavirus, or COVID-19. The most important thing I can tell you today about COVID-19 is that we need to focus on preparing and not panicking. That's a very important point. There are many types of coronaviruses. Coronaviruses are behind the common cold, they're behind SARS, they are behind MERS. But in the terms of severity, we are still learning where this new virus falls. And we do know that COVID-19 is a serious public health threat, but we don't have all the information just yet. And even though the United States population remains at low risk for becoming infected with the new virus, as you have heard, cases of COVID-19 are being diagnosed in greater and greater numbers across more and more countries, across Europe and Asia and the Middle East. Local spread or community transmission has been confirmed in these areas, and up to now, a limited number of cases have been diagnosed in the United States, mainly among travelers returning from China and their close family contacts or quarantined repatriates. This week, the Centers for Disease Control and Prevention warned Americans to prepare for the inevitable spread of COVID-19 within the United States. And on Wednesday evening, the CDC reported that the first case of COVID-19 without the individual having traveled to regions hit by the outbreak or coming in contact with anyone known to have the infection. Now, this California case is the first sign that there may be community transmission within the United States. And the department is closely monitoring global, national, and local developments, and is in daily communication with our colleagues at HHS, particularly CDC, the Port Authority of New York and New Jersey, the New York City Department of Health and Mental Hygiene, and our 57 other county health departments that we oversee. And as well as our colleagues at other state agencies, healthcare facilities, providers and associations, are in contact with all of them, as well as colleges and universities. Now, as of this writing, there are no cases, still no confirmed cases of COVID-19 in New York State. Samples from 28 New Yorkers, 6 in New York City, and 21 outside the city have been sent to the CDC for testing, and 27 have come back negative. And we're still waiting for test results on the most recent person under interest. There is much anxiety about how well prepared we are at the state, at the federal, at the local levels to handle a large-scale outbreak. And the World Health Organization has declared COVID-19 a global public health emergency. And I know that many Americans are worried about what comes next, specifically the possible WHO declaration of COVID-19 as a pandemic. So I thought that a good way to put this situation into context is to briefly revisit how New York State wisely prepared for and then very successfully navigate a global pandemic just 13 years ago. So New York State's preparation for an influenza pandemic is a continuous process. And one may ask, why is that? Because every year, right, influenza kills between 600,000 and 700,000 people across the globe. And from October 1 of 2019 through February 15, 2020, just last week, the CDC has estimated that there could be as many as 41,000 flu deaths. Now, while COVID-19 does not pose any immediate threat to New Yorkers, influenza is still prevalent and has tragically claimed the lives of 9 children this year. This week, even as we reach a record-breaking total of 131,604 flu cases overall, the number of laboratory-confirmed influenza cases declined for the second week in a row since the flu was categorized as a widespread situation across New York, which happened in December. And this week's decrease in lab-confirmed cases was 26%, and hospitalizations decreased 13%. The department's pandemic preparedness efforts are critical, but because this work is carried out in the background to public health concerns that spike and recede with media attention, the public is generally unaware of all that we do. And in June 2007, New York State decided to evaluate the influenza pandemic preparedness of our 4 state public health laboratories, New York City, Westchester, Erie, and Wadsworth Center in Albany. We did this by executing a surge drill at all 4 locations. And the results from this drill were great. New York is ready. The lessons from these surge drills proved instrumental during the novel influenza H1N1 pandemic that emerged in the United States 2 years after that. And on June 11th, 2009, the WHO declared the ongoing outbreak of influenza A H1N1 the first influenza pandemic of the 21st century. The WHO declared this virus a new strain of influenza A, subtype H1N1, that was first identified at Wadsworth Center in April 2009. And in 2009, the department reported a total of 53,930 lab-confirmed influenza cases statewide, and that included New York City. It's 2009. The total influenza-associated fatalities in the United States during the first 12 months following the emergence of influenza A H1N1 has been estimated at 12,469. Now, during the pandemic, the department's incident management system, the IMS, was central to all communication and coordination of efforts. And these statewide conference calls enabled the sharing of experiences with state, regional, and local health departments. Participants identified limitations and problems and discussed the best laboratory practices and regulatory issues that arose during the pandemic. And in 2009 to 2010, the department's IMS had been activated for 286 days with daily statewide calls to all services and all relevant agencies. And I want to note that the department's IMS was critical to our effective response to the historic outbreak of measles in the lower Hudson Valley during the fall of 2018 to the fall of 2019. The 2009 influenza pandemic demonstrated how preparedness plans need to be comprehensive, workable, updated regularly, and integrated with a multi-hazard public health emergency plan for rapid implementation. Since 2010, the department has continuously developed and refined our influenza pandemic preparedness and other response efforts. This history of preparedness puts New York State in a solid place as we face a possible COVID-19 pandemic. So now I'll run through the action plans New York State has implemented for COVID-19 and preview our plan for pivoting our response efforts in the event that there is a larger outbreak. There are travel restrictions in place at varying levels. For China and South Korea, level 3, avoid travel. For Iran, Italy, and Japan, level 2, postpone non-essential travel. And for Hong Kong, level 1, practice usual precautions. And New York's JFK Airport is one of 11 airports designated to receive passengers from China. And we've collaborated closely with U.S. Customs and Border Protection, CBP, and CDC to screen passengers returning from China for symptoms, travel to the Hubei province, and close contacts. The CDC provides the department with names and available contact information of travelers from China screened by the Border Protection, Customs and Border Protection on a daily basis. And so since February 3rd, the department has received the names of approximately 7,000 individuals in New York State, outside of New York City, and is working with local health departments for appropriate monitoring. The numbers being monitored changes almost daily due to ongoing travel from mainland China, validation of need for monitoring for certain individuals after initial interviews, and as a result of completion of monitoring periods. This does not mean that all of these people have been self-isolated and monitored, but that they have at least been contacted by their local health departments to determine whether they meet the CDC criteria for self-isolation and monitoring. And we are advising New York State counties that travelers who have been in Hubei province in the 14 days prior to arrival in the United States be quarantined for 14 days. Travelers who have not been in the Hubei province, but in other parts of mainland China in the 14 days prior to arrival in the United States are being asked to self-isolate at home and monitor themselves for symptoms for 14 days. We are working closely with counties to ensure that they properly carry out these quarantine procedures and provide needed supports to individuals. And we have added COVID-19 as a reportable communicable disease so that the department can better monitor possible cases. We are working closely with schools and universities to ensure their understanding of this public health process and implementation through public health authorities. Wadsworth Center was one of the 5 U.S. public health laboratories that usually test for influenza that the CDC authorized to begin diagnostic testing for COVID-19 2 weeks ago. But several CD test kits sent to the public health labs, including those sent to Wadsworth, had an issue with a test reagent and could not be used. So on Wednesday, the CDC announced a modified protocol that states could use if 2 of the 3 reagents sent with the test kits were functioning. Unfortunately, in the kits both New York State and New York City received, 2 of the 3 reagents failed, so we are unable to use the modified protocol. However, Wadsworth Center has developed the department's own test that is very efficient at identifying the virus, and we are awaiting FDA approval to use it. Upon FDA approval, Wadsworth
Mic check,
will
1 2
begin testing to support New York State and other states in the Northeast if necessary. And I hope to hear that soon, the answers from them. We are from the FDA, I should say. We are actively working to educate New Yorkers on COVID-19 transmission and threat level and to dispel misinformation, because there's a lot out there. We are trying in all communications to encourage New Yorkers to remain calm and act rationally, use good common sense. And as a physician, I know that the worried well would always like to be less worried, right? So we see this all the time. These well individuals who don't have symptoms, haven't had any exposures, and there are people who have had symptoms of other respiratory viruses, as there are many circulating viruses at this time of year, but no exposures to COVID-19 for those individuals. So both groups may want to be tested, but is not necessary or efficient. We have risk criteria and symptomatology that we use to determine when we test for any disease. For example, we don't test everyone who has a cold for the flu or strep. We let the symptoms sort of guide us. And we are also very flexible as the things we know about coronavirus change, or as we see community transmission, we'll change how and who we test at that time. We are reminding everyone that there are simple steps you can take to prevent transmission of all viruses, colds, flus, as well as COVID-19. The use of face masks are not recommended for use by well persons in the community, except under special high-risk circumstances, such as caring for an infected family member at home. Face masks are recommended for healthcare workers. The department has opened up a coronavirus hotline where New Yorkers with questions about the virus can speak with public health experts in their preferred language. And since the hotline opened on February 3rd, we've received over 1,100 calls. We maintain a dedicated COVID-19 webpage with informational videos available in Cantonese, Mandarin, and Korean, as well as in English. And educational and information is key. In the past 5 weeks, the governor has asked me to address COVID-19 during at least 5 press conferences, and we have issued more than 10 press releases on COVID-19 to both raise awareness and reassure New Yorkers. We are also committed to combating any anti-Asian racism and xenophobia that has arisen from this outbreak. We have been reaching out with bilingual information and ads in Chinese American community publications to offer support. This week, the governor announced key measures to ensure that the New York State Department of Health will have the full capacity to respond to a potential COVID-19 pandemic. He has committed funds for the department to hire additional staff and procure equipment and any other resources as necessary. And he will provide legislation to grant me as commissioner the authority to ensure that all local health departments and the state's public and private hospitals follow prescribed actions and measures in the event of a large outbreak of COVID-19. We are taking lessons learned from the 2009-2010 pandemic and subsequent surge drills and applying them to COVID-19. We're assessing the information on past influenza pandemics for comparison, as you can see here on this slide. We're considering both clinical severity and transmissibility. Again, you can see that here on the slide. The y-axis is transmissibility, and the x-axis is severity. Exploring 4 pre-pandemic planning scenarios based on potential severity. You can see the 1918 pandemic up in the far right corner, high severity level and markedly transmissible. A key component of our plan is implementing non-pharmacological interventions, or NPIs, statewide. Now, although the NIH and other medical research institutions are working aggressively on a COVID-19 vaccine, this will take more than a year. This is what Tony Fauci had mentioned at NIH the other day. COVID-19 could still be with us into next flu season, so personal, community, and environmental NPIs are critical responses for a potential pandemic. NPIs are strongly encouraged by the CDC and can reduce the societal impact and total number of cases during an influenza pandemic. So community mitigation plans have 3 goals. One is to delay the exponential growth in cases, so it provides more time for preparation, allows the flu season to end. You can see the delay is on the hatched curve there on the bottom towards the right. It decreases the height of the peak. It eases the peak demand on healthcare and public health systems. You can see that dark purple is quite demanding. It's lower in the bottom curve. It reduces the total number of cases. NPI implementation can be easy, targeted, and layered, and early. Preventing the spread of infectious diseases is the essence of public health work, and the scale of efforts by state and local health departments across the country to contain COVID-19 has been amazing. Although New York State has not yet confirmed a case of the coronavirus, we know that is coming sooner or later. Our preparation work is in full force, and in the coming weeks, we will convene local health departments and hospitals statewide to review protocols, best practices, and procedures to help ensure they are prepared to combat the spread of COVID-19. And so in closing, I want to stress the Department of New York State and the Department of Health have expertise and experience in responding to respiratory outbreaks. We have detailed plans that have been in place for more than a decade, and we are very well prepared for this response in New York State. These are some of the people in our lab. They're ready to do whatever tests we need to do. Whatever threat that the coronavirus ultimately presents, we know that New York State and local governments and members of the community can all work together successfully against a common foe. And the strength of character, the spirit of community, and the smarts of collective wisdom can conquer the challenges, any virus that nature sends our way. And I'm sure that we will be able to do it with this. And I look forward to answering your questions and to your partnership as we move forward. Thanks a lot.
Thank you very much, Commissioner Zucker. I'd now like to introduce 2 faculty panelists from NYU School of Global Public Health. 3 panelists from NYU School of Global Public Health who will ask Dr. Zucker a few questions, and we will then open up to the press and audience Q&A. First, Dr. Josh Epstein, a professor of epidemiology and an expert in agent-based modeling of the spread of epidemics.
Thank you, Cheryl. Thank you, Dr. Zucker, for joining us. I had a couple questions along the lines of, hope for the best, plan for the worst. But as you know, Japan closed schools for a month a few days ago. And we did a study of this during swine flu, that you recall, where we closed U.S. schools for a month, and it cost up to $50 billion and produced absentee healthcare workers of up to 20%. So school closures have impacts beyond the interruption of classes, and there are both economic and epidemic implications. And even though, thankfully, children seem to be less vulnerable to COVID-19 than elderly individuals, I'm wondering, are you contemplating school closures? And if so, how do you plan to mitigate these economic and other side effects?
Well, we're not contemplating school closures. We feel that as this were to evolve, if there's a specific area where there's a school and there's a lot of, if there's community spread and there are a lot of children sick or a lot of teachers sick, then we'll address it at that time regarding that specific school, but not a blanket statement to say we'll just close schools.
Yeah, that sounds reasonable to me. Second question on vaccine. You mentioned in your talk about swine flu that this is on the list of your critical containment components. And as you note, Director Fauci is working on a vaccine. It may be a year away, and the fact that he's proceeding with that indicates, as you also note, that he expects this to be with us for some time. And it may even become a routine presence in the United States. So you also recall, I'm sure, from swine flu that roughly half of Americans refused the swine flu vaccine despite WHO declaring it a global pandemic. And vaccine refusal is central to the resurgence of measles, as you know. WHO actually ranks vaccine refusal as one of the top 10 global health threats. And there's an arms race to develop a vaccine. Moderna and Migal are both trying to do this fast. And I'm just wondering, what will you do to increase the uptake of vaccine once we do have it?
Well, I think a couple things. One is, a lot of this is about education. We just experienced this with measles, as you mentioned, and I think there are many lessons we learned from that. We need to work, obviously, with the community. We need to address a lot of the misinformation that's out there. We need to partner with our colleagues in community health clinics and physicians and nurse practitioners. And I think that if people recognize that vaccines are safe and effective and this can prevent someone from getting sick, I hope that they will move forward and get vaccinated. I mean, we deal with this every year with the flu, and as I mentioned, we've had over 140,000 flu cases this year, and I would hope that people recognize the benefits of vaccines, and we will push that message.
Great.
Next, Dr. Elodie Ghedin, a molecular parasitologist, virologist, and professor of epidemiology. Dr. Ghedin uses genomic tools to explore host-pathogen interactions and severe disease outcomes related to parasites and other pathogens. Dr. Ghedin.
Thank you very much. I have a question about the testing. You explained really clearly what the protocol in place has, the testing of people who are symptomatic. And I do work on flu where we still, although we know how the virus is transmitted, we know what the incubation period is, and our preparedness and response, as you described, is based on flu pandemics mostly. However, one question that remains in flu transmission is also how many asymptomatics are out there. We don't know that for flu, but we really don't know that for this new virus. So if it were possible, you described these new kits, test kits that the Wadsworth has developed. If it was possible and there were enough kits to go around, wouldn't it make sense to test everyone that is traveling from a hot zone rather than just the symptomatics, especially that we don't know whether the incubation period is 2 days or 14 days? Is that even feasible?
So it's the feasibility would be really if we can scale up, and it depends on the numbers, and I'd have to look at that. But I think we should always tailor our response to the clinical picture. But I understand what you're saying about a specific region. So if you have someone coming in from a region where there's a significant amount of disease and they're on an airplane and they arrive and we're concerned, then maybe it would be in some ways helpful to do that. But I don't want to, again, have a blanket statement, because this is changing so much. And one of the dangers of putting something out there and saying this is what we're going to do is that may not be as effective or necessary 48 hours or a week later or 2 weeks later. But it's something we would think about.
Yeah, so I totally agree with you. I like the fact that you're saying that there's flexibility that's built into your preparedness, because that is the most important.
I think in a lot of ways one could look at this in a similar way to a storm. You have a storm that's coming in, it's off the coast of Florida, right? And they predict, well, it may hit the coast of Florida, it may hit South Carolina, it may hit further up, it may go across Florida, but you don't know on that day. It's nature. Nature does things in its own way, right? And so you prepare for what could happen and then you adjust accordingly. So we are early on in this, and this may burn out, it may last longer, it may the virus may mutate, and I think that we always should prepare for the worst, but be available to respond in real time when necessary.
It's funny to use the analogy of weather, because a lot of the modeling, as Josh Epstein does, is using a lot of the tools that have been developed for prediction of weather, right, John?
Yes, and we're about at the same level of confidence. We can give these very, very broad 180-degree cones of possible futures. But yeah, no, I think you're taking a sensible approach.
Yeah.
Elodie, did you want to ask another question before we move on to Mike?
I'll move on to Mike.
Sure. And then go back.
Just for time-wise.
So I'd like to introduce Dr. Michael Merson, a visiting professor here at NYU GPH and director of the Sing Health Duke National University of Singapore Global Health Institute. Michael.
Well, first, Commissioner, thank you for all you're doing.
How are you?
Okay, and you have a great challenge ahead of you. And I was going to ask you about the test kits, because after the news in California this morning, and your fellow commissioner, they're saying there were only 200 kits available at the moment. That was news but the fact that you've got real prospects here and have a plan, I think that's very reassuring and obviously a real priority. I do, though, would like to ask you about one other issue you mentioned, and that's communications. I'm interested to know more, because what we're seeing, as you know, there's a huge amount of information out there. You obviously, as you showed on your slides, want to be sure the public has clear, accurate, and timely information. On the other hand, there's the fake news and rumors that are very hard for a state health department to quell. I work in Singapore, as you heard, and there's almost 100 cases there. I've seen how well communications can be done, but even there were 2 miles long lines for masks. In a country which has really done a great job in communications. So I'm just wondering what you can do, because clearly if we get our first case tomorrow, you're going to have a big task on your hands in the communication space.
I think, well, two things. One is regarding the tests. We are thrilled that we have Wadsworth Central Lab here, because the experts there and the tests they've developed and the knowledge is just fantastic. So I'm fortunate to have the lab here in New York. The issue of communication is really important. And in a lot of ways, in some ways, it's one of the most critical parts of our response to this, because if there's misinformation out there and it starts to spread, the domino effect, the panic, the worry, the people running to the store, buying products, it becomes overwhelming. And so I feel my role and the role of all people in public health is really to communicate the message that this is not something to overreact to look at the science. And there has been a real tendency over the last couple of years, and not just in health and medicine, but in many areas where people are no longer looking at the data and the science about things, and they're just making their own assessment based on what they sort of read. And I think it's important when you're dealing with something of this nature is to make sure you look at the data, look at the science, and make a decision that way, and have the experts who study this, like all of you on the panel there, be able to carry that message to the public. And we should use the devices we have where we get information, and sometimes that information is wrong, but we should use that information to be able to help convey the right facts to the public.
Okay, I have one other question, which looking forward a little bit and thinking about the storm you're worried about, and right now, of course, and having enough kits and supplies and beds and not wanting to have an onslaught of cases to slow down any transmission, as you showed very nicely on your graph. But, we could reach a situation, just as a little bit provocative here, but where many persons are exposed, develop, most of them a mild illness, and maybe, as you've indicated, coronavirus could be here to stay. And this would mean that you'd obviously want to put resources and efforts in our preventive measures and treatment modalities, hopefully having a drug and a vaccine or a year or so. But what about the idea that COVID-19 could be the new normal, as it is for influenza? And, what about that? And is that something we all in public health maybe need to think about? Of course, right now we're in the moment of the storm. But if we think a little bit beyond the storm, what might happen?
Well, I think that's a great point. And I think that if it does become the new normal, and if, as Tony Fauci says, there's a vaccine, let's say in 18 months from now, perhaps, as one of you mentioned, that it ends up being that vaccine that you get every year. I mean, we give people, right, a pneumococcus vaccine, right, depending on the age. We give the flu vaccine. We give all those childhood immunizations that we have for much more of a lifelong immunity. But maybe you sort of say, well, this has enough of a morbidity or the potential for mortality that you would say every season, if this is around, you should get this vaccine. So I think we're going to sort that out. And again, that's one of those things that the experts looking at vaccines and the virologists look at, and we'll figure out what we should do. And maybe that becomes, as much as this is part of the new normal of diseases, that becomes part of the new normal of response or prevention, I should say.
Just one last follow-up. I'm wondering how, with all that you're dealing with now, you're able to continue all your other public health functions up there. Are you able to continue dealing with non-communicable diseases and other many challenges that you have, or is it pretty much full-time everybody on this?
No, yesterday I was out on Long Island and we were talking about vaping, because remember, that was only a few months ago and it's still going on and it's still a concern, and it's in the school systems, and we're trying to address e-cigarettes and we're moving forward on that. And there's so many other issues that we tackle. It's just a matter of like whether you need to sleep. And so if you cut back on the sleep a little bit, you get a little bit more time, you could do things. But we have an incredible team of experts up here and everybody's working very hard. This is something we do on a regular basis. And in my tenure here in this role, we've had this happen many times. So whether we've had 2 very bad flu seasons. This season has more flu cases than we've ever had on record. And a couple of years ago, we had a bad flu season. We had the Zika outbreak. We had the concern about Ebola. Downstate, we had Legionella. Upstate, we had a water issue. We had the measles outbreak in Hudson Valley, Lower Hudson Valley. So, and now we have coronavirus. And the team always rises to the occasion. The lab always is able to tackle the issues that come forth. And I'm fortunate to have so many superstars within the department.
We're going to let Josh and Elodie have one last question. And you do have superstars, and I'm going to say this because I don't think the commissioner would want to say it, but I don't think there's a state better prepared to address this problem than the state of New York. It's had, for a long time, one of the strongest health departments in the country.
Thank you.
Josh or Elodie,
Sure.
whichever.
Well, we talked a little bit about school closures and vaccines, and you mentioned another topic dear to my heart, which is contagious panic, which we also model equally badly, I'm sure. But I wonder if you would agree that one of the a little knowledge is a dangerous thing, and one of the indexes that has caused a lot of panic is this R0 number that everybody hears about.
Yes.
And people think about it as if it were a number like rabbits doubling. If the R0 is 2, then you start with one rabbit. He gives it to 2. They each give it to 2, so there's 4. they give it to 2, so it's 8, so it's 16. But if you only have 10 rabbits, for example, it can't go 1, 2, 4, 8, 16 because you run out of rabbits. And diseases saturate at a certain point, and we've seen this in China. The rate of new cases has fallen dramatically now, and I think it would be, I'm just wondering if you agree that the abuse of measures like that contributes to an unnecessary panic about this epidemic.
Right, and I think you're right. I think that this is where a little knowledge can be dangerous. And I think what's so important is that the public recognize that that's why there are experts out there. If someone asked me, they said, well, what do you think about how we should fix the George Washington Bridge? Because they're fixing it now. If I say, well, this is what I think they should do with the cables, and someone will look at me and say, well, what do you know about cables on the George Washington Bridge? I know nothing about it. And so I trust the person who's putting those cables and replacing them knows what they're doing. And that's why they're the experts. And the same with us. We're the public health experts. And the public should say, I trust that they're doing the right thing. And we are.
Just to come back to Josh's comment, isn't that the point of quarantine, where you're trying to limit the number of people who would be exposed and then it dies off,
Absolutely
right?
Absolutely.
Yes.
So it sounds like New York State is super well prepared, but other countries have had time to prepare also. We've been talking about flu pandemics for decades. And it seems that you take examples, we see what's happening in Italy, and often, in the case of Italy, it seems that there's also political influence in the way they've been testing or not testing everybody and what they're doing with the quarantine. And it seems like we're all learning in real time. And it hasn't happened here yet, so we don't really know whether we'll also be learning in real time. Do you think we can learn in real time? And are you set up so that there is enough flexibility so that you can readjust very quickly without a whole baggage of paperwork or whatever it takes to be able to readjust the response?
So we have a great system put into place here. We have an incident management system where whenever there's a problem that seems like it's not going to go away, it's been around for, let's say, even a week or so, there's a concern, we bring everyone together, and that involves probably between 60 and 70 people, and it touches upon all aspects of the department. And because everyone's in the same room and we meet initially like every day, and then we may switch it to every other day, but it's immediate response to an issue that's brought up. And there is flexibility. When you have a lot of people around the table reporting out, and there's a lot of institutional memory and a lot of talent and knowledge, you're able to be flexible and figure out solutions to problems as they come up. And I think that that's one of the things that we do very well. And I think it's very helpful in tackling this problem or any of the other problems we've come across.
Well, thank you. We're ready to open up to the audience, and we have a mic that is available. If anyone in the audience has any questions, please raise your hand. I see one hand raised, 2, 3, 4. Okay. Here's 5 people, Howard, so we're going to run you right up to the end of your clock, I think, there.
That's fine. That's good.
Hi, Dr. Zucker.
I'm good.
This is Melanie West from the Wall Street Journal. I have a question.
I can't. 1 second. We can't hear you.
Okay, hold on. Hi, can you hear me now?
Here we go.
Thank you.
I do now.
Dr. Zucker, this is Melanie West from the Wall Street Journal. How are you?
I'm good.
I want to ask about the testing, which I think has been of confusion to many people. The way it sounds is that whatever works in Atlanta isn't working in Wadsworth. So I want to understand in the plainest language possible what the challenges are in importing the test into New York, and then also understand whatever it is that Wadsworth developed. Did it come directly from, your laboratory scientists or from another country? It's just confusing why tests aren't working everywhere
Sure.
they're supposed to.
Sure. So the test that we have developed at Wadsworth is based on the protocols that CDC gave us, and that we worked with those protocols to develop the test vote. The test that CDC has put forth, there are 2 parts of the 3 that didn't, they were not working effectively for us. And so as a result of that, we feel that we were going to develop our own test. And there are other parts of the country also that have been able to develop their own tests. It's not something that we have brought in from another country.
You could indicate who you are.
Thank you, Dr. Zucker. Glenn Maris, NYU Dentistry.
How are you?
It's a pleasure to see you here today. The question I have, and I want to thank you for your organization and others for the conference calls that we have weekly so that we on the ground can have as much information as possible. And we talk about PPE conservation strategies. The difficulty has been with masks. And whatever the outcome is concerning the California case or the next case that comes out that we do have a community infection, the concern, I think, for many providers, at least from dentistry in their private practices, are finding difficulty in getting masks. And I don't know of a public relations situation other than what's happening over the past several days, telling the general public that wearing a mask is not going to protect you because you don't necessarily wear it correctly. Is there any thought possibly to ombudspersons through the State Department of Health that may help those individuals who, even though trying to prepare for 30, 60, or 90 days, who may be having difficulties getting certain types of personal protective equipment? And thank you so much for your guidance.
Sure. Let me think about that as a possibility. I will tell you that we do have masks in our stockpile. However, I think the bigger point is what you started discussing there, is that the public needs to recognize that wearing a mask is not going to be helpful to them unless they're in the house with somebody who actually is sick, or if they're sick themselves. But the masks should be reserved for the healthcare workers. And this is where I believe we need to work together as a community. And I think that the success of tackling this or any other problem of this nature or scale is when people take a little ownership and say, I have to also look out for my neighbor, and realize that my wearing a mask is probably not going to help me, and it's probably only taking away from the healthcare providers who need it. So I've been carrying that message out to the public, and also whenever I have an opportunity to speak with any of the news outlets who write about this. And I think that's really important that they understand that, particularly in some areas of the state where there has been a lot of use of masks because of messages they may have received from other parts of the world.
We have a mic in the center for anybody who now wants to get online. We will take people in order the line at the mic. Please, go ahead.
Thank you. Thank you, Commissioner. Ananda Dasanayak, Professor of Epidemiology, NYU College of Dentistry. So when you're showing some of the data, I think it's the Hopkins site, the global numbers, one could not help but wonder about the validity of some of the information because of the socio-political and cultural aspects related to reporting. So that is one side of the story. The second one is, in the US, in our own state, do we see the whole iceberg? How confident are you about the latest information that we get and the quality and the validity of that information?
Sure. So I think on the first part of that question regarding the information that we're receiving from overseas, not just the United States, but the World Health Organization, let's say, so they're saying numbers in the 80,000 range. So we don't know the denominator really on this, because there may be people who are sick, who get sick, get better, and they've never even been tested or evaluated or seen by a health professional. So that does come into play because it may actually lower your case fatality rate, because the number of people who died, which we would know, right, because of their illness, may actually be a smaller percentage of the total number of people who are ill. But the bottom line is that we do know it's an infectious disease that is spreading is in multiple different countries. We have cases here in the United States, and we have to prepare appropriately for any kind of outbreak that could occur. When it comes to communal spread, obviously that's something else which is of concern. I didn't catch your second question, which was about the communal spread.
Yes, it is the numbers that we're talking about in the States and the United States. Do we have an underestimation? Do we have an overestimation?
Okay.
Or are we seeing the whole iceberg?
Right. So in the United States, we have these numbers. If there was increased communal spread, people would end up showing up in an emergency room. And we have a very aggressive health system in the United States. New York, elsewhere, someone is going to, it's high on their radar. Someone's going to send that test off, and we would know if there are other cases out there. So I think we're very vigilant in identifying cases at this point. Again, things evolve. If it becomes more of a communal spread, that will change. that will change the other variables that we were talking about, diagnostic tests, if there are antivirals that were available. So I think this is a little bit of a fluid system, but we're on top of this, whether in New York and I suspect elsewhere as well.
Dr. Silver?
Hi, Diana Silver, the School of Global Public Health. I wanted to ask you about the way in which you may be thinking about the impact of the public charge ruling from the Supreme Court on this idea of people coming forward if they do have symptoms. It is the one thing that we might say has changed since the other epidemics that you've spoken about. And I just wondered how you guys are thinking about it and what plans you might have in place.
I think anyone who comes in that's in the country that has symptoms, that health sort of eclipses everything else, and that you should evaluate them and treat them accordingly because it's an issue for their safety as well as the safety of everyone in the community.
I think maybe Diana was saying that we need to step up the communication so
Right.
that they
I'm
know
not sure that people would come. I think the public health community has been concerned that people would not be coming forward, given that the public charge suggests that it will imperil their immigration status. So I just wondered if you guys are thinking that through.
Well, I think this is where, again, communication and messaging is to tell people that they should come forward and not to, that in New York, I can speak for New York, that we will make sure that everyone is cared for and they should not let anything jeopardize their ability to get quality health care if they're sick.
It's great to hear. Next.
Hi, my name is Michael Clark. I'm a student of public health here at NYU. And I have every confidence in New York State's response. So thank you very much for instilling a lot of trust. But my question really relates to the social response and resources. Specifically, like I was looking at a medication that I take every day that I depend on for my health, and it's manufactured in China. And I know that a lot of other people have had this similar questions, is considering that there is a lot of factories shutting down and Apple has reduced their production, all that kind of stuff, is medication something we have to worry about considering so much of what we depend on comes from China?
So this is the issue of globalization and the challenges when you have supplies coming in from around the world, particularly China. We have been speaking about this, not just New York, but the entire health system in the federal government and others have been speaking about this, about are there other sources of getting medications, other medical supplies if necessary. And so we've been looking at that right now because you don't want it to be all from one place. But fortunately, there are many different companies from around the world that do make different types of medications, and we will address that as well. And I hear you.
Hello, Commissioner. My name is Zach Williams. I am also an MPH student here at the School of Global Public Health. I have a question related to the discrimination that has come out because of the coronavirus out of China. I know you had a brief general overview of it, but I was hoping that you can drill in a little bit more specifically as to what the New York State's Department of Health's plans are to tackle the discrimination, because even if the coronavirus does maybe fizzle out, the trauma and the social impacts of that discrimination will last much longer. Thank you.
Sure. So there's two parts to that. One is from the standpoint of the people who are in a community where they are getting discriminated against. It's for them to understand that we, as a state, the governor does not tolerate any types of hate towards any group of any kind in the state. And he has actually had a whole press conference about that just yesterday, and that he will tackle that in the way that he considers that domestic terrorism. So New York is right on top of that issue from that standpoint. And I think it's very important for all of us to recognize that that is not the New York way, and it's not the American way. And so I think it's really important for people to realize that we all need to work together on this. But I have heard that, and I'm concerned about it.
We're going to have two more questions here, and thank you again, Dr. Zucker.
Hi, Dr. Zucker. Thank you for your wonderful speech, and Thank you all for your questions. I'm a medical graduate from Taiwan, and in Taiwan there are about 25 cases, confirmed cases, because many of the Taiwanese people worked in China and they returned to Taiwan for to receive medical care, and my friend who is a pediatrician who works in a local clinic, she says that they have access to masks. But it's like they receive N95 for they receive 3 N95 for an unknown period. So I'm just wondering, do any of you have any suggestions in coping with this situation and how to improve this? Thank you.
Well, I think it goes back to the issues that we spoke about before, about the right kinds of information to make sure that people realize that the use of a mask, if you're healthy, is not going to be beneficial, and unless somebody is sick and that you're taking care of them, you should not be wearing a mask, and to reserve those for the healthcare professionals. I have heard a lot of them are out there, and as one of the members in the audience has mentioned, is that people often put those masks on incorrectly, and so that's not really that effective. And if you really want to use these masks effectively, there are many different things that are done, usually to test it, and I've had them on. They're actually not that comfortable if you're really wearing them in the proper way. You have to have a hood put over you, and they spray a little sweet smell, and they're supposed to see if you actually smell it, and if you do, then you don't have the mask on very well. So why give the masks out if they're not going to be used effectively? You might as well allow the healthcare professionals to use that, and that's what we're recommending.
So about the because it's more serious situation, because more people would maybe return from China, and so how to better cope with this situation in the long term. It's
communication, it's messaging and communication. That's what we all could do. That's what we're working on from this end at the state level, but also for everyone in the community, everyone in the public health community, to carry the correct messages. And I think that will tamp down any of these inaccurate facts that are being communicated.
Thank you. Dr. Abramson?
Hi, David Abramson on the faculty here at the School of Global Public Health. I had a question about how the state supports the quarantine. You mentioned that there are 7,000 people living outside of New York City that are presently being supported as part of the quarantine measures, up to and including providing food, providing medicine, and other supports. What happens if that number exponentiates a lot? At this point, with 7,000, that's maybe handled by the locals. What happens when that gets to was that not the number that you referenced?
700. 700.
700.
I may have said 7,000.
It makes it even more of a point then. If it's 700, you can imagine that if the cases really come to the state, that will exponentiate and we'll have a lot more people under quarantine. So the question is, how does the state handle that kind of increased burden? Do you have plans to open up specific sites or institutions or anything else to allow for quarantines? Do you have a way to support local health departments that might be overwhelmed by the efforts to try and monitor the quarantine cases in their jurisdiction? And the last part of that is, would you change the criteria that allow for support so that you don't offer as much support because you can't when you have so many people in quarantine?
Right. So we are working. We have developed a system with the counties to make sure they have a place for quarantine for individuals that need quarantine who can't be monitored just at home, and those who are being just watched at home, which is different, just home monitoring, are providing to the state at the state level information. We're checking on them, either whether through text messaging or other systems. I get your point as to what if this gets a lot larger, then what do you do? And we are looking at that both from the standpoint of what we can do, legally can do, and also what other facilities or ways we can address that. So again, this is part of the plan as we move forward, and recognizing that this is not something that we could sit around and say, well, in 2 months from now we'll come up with it. So we've had meetings about this issue, multiple meetings about this exact issue in the course of the last 2 days. So, and prior to that as well. So we're on top of that, recognizing that communal spread may mean something. But again, we really should sit back and think about, like, what does this mean if someone gets sick and if it's in the community, then you stay home. So good hand washing, stay home, cough into your sleep, good public health practice will prevent this from spreading within a community. So we are looking at that.
Can I ask one follow-up?
It's going to be quick.
Okay, it's very quick, which is there a number that is a tipping point for you, that if a certain number is hit, you feel like that's when you have to sort of ramp it up to another level?
I don't usually like to fixate on a number, because let me give you an example of what happened with measles. So we had one community that had many cases, where, ultimately with over 1,000 cases, and that was in one community. So my response was tailored to that community. If I had cases across the state, I would look at it a little bit differently. So I try to tailor things to the situation at hand. But I do keep in the back of my head, okay, look down the road. What do we need to do? What happens if there's a communal spread? What happens if the case fatality rate is higher? What happens if there's other issues from other countries? And we just measure, and that's what we keep tracking.
You have been absolutely superb, and on behalf of everyone here and the College of Global Public Health and the state of New York, I thank you.
Thank you. Can I just ask a question of Dr. Merson? I am curious about Singapore and what else is happening there, because you're in Asia, and I was curious as to what you're seeing.
The Singapore, as you know, is a small country, 5 million people, and they went to code yellow, which was started with code yellow, went up to code orange, did not go to code red. And that's because they felt, although 2/3 of the cases in Singapore were community-based, the first third were linked to a China visit, but the latter 2/3 have been community spread. But they have been able to identify these cases aggressively, figure out where there's been small clusters, and appropriately quarantine and isolate people as needed. Being Singapore, they can enforce pretty strongly a 14-day quarantine, etc. They've had no deaths, and they have constant messages from the head of state, almost initially on a daily basis, assuring the public, providing the right information to try to really enforce key preventive measures. And I think the key word I would use in Singapore has been trust. And you have a population there that fully trusts the messages they're getting and willing to follow them. And, we've had the last 2 days, it's been challenging in this country in terms of some of the messages we're getting. But I think consistent messages that we as a nation can trust and follow is key. And that's what's made the difference in Singapore. There's still some spread, a few cases every day. Many people are working at home. Classes are going on at university. If they're below 25, classes over 25 are being done through online. Companies have a combination as well of both online and small meetings. But it is a country that has set standards and guidelines that people follow. I think that's the thing I would emphasize. And again, I come back to trust. If people believe the messages they're hearing, there still were long lines for masks, which surprised me. Other than that, I would say they're a real exemplar of how to manage an epidemic of this type. I don't know if you have any specific questions, but that...
No. Thank you. No, that's great. I think the point of trust is really a very important one.
You exude trust.
Thank you. Thank you.
Reduce trust.
Thank you for inviting me. Sorry I couldn't be there in person.